Well, we're in for a good treat tonight. How many nurses do we have here tonight by chance? Raise your hand. 1, 2, 3.
4.
There's none?
You.
Oh, well, I had my hand raised. Okay. Okay. So, we're so, see, somebody's come in late. I told you that.
So see, you waited, no, they aren't.
So, Janice has an extensive, awesome bio for nursing. She was gone from Mount Holly High School, hey Phyllis, to Masters of Nursing. So, we are so excited to have her with us tonight, and it's quite an honor to know her, and especially as she was one of the North Carolina 100 nurses. That is a great honor in our field, and that is the best of the best. So, also, Janice has been very active in our community. She did not mention all that to me, but we know that she is all over Mount Holly for a long time, different committees, Community Development Foundation. There's too many things you could even tell about her in the community. And I see her at the city council meetings doing her thing, and she volunteers here at the museum on a regular basis and whenever we ask her. And I don't know if some of you may not know that she has been the 2024 Mount Holly Woman of the Year. So we're real proud of that too. So I'm not going to take up much of her time or let you come on up. Welcome.
All right, Gary. Okay, Gary had to give me a lesson. Can you hear me?
Yeah.
I promised I would be loud enough if I didn't use this, but John and Karen told me I really needed to. I never had a problem with my students hearing me,
Well,
so
we wanted to pick up on the,
on the video,
Yeah.
so I've got it. But you know, when Camille asked me about this, I said, yeah, and then I started thinking about it. I thought, what in the world am I going to tell them? I mean, I have always worked pediatrics or neonatal intensive care, so my nursing is not, you know, I only took students to adult floors, and that's as much as I wanted. I never wanted to take care of adults. When I first started, you know, they asked me where I wanted to go to work, and I talked to Nancy Snap, was the nurse at Presbyterian that you had to interview with. Anybody that went to work there had to interview with that director of nursing. And she looked at me and she said something about where did I want to work, and I said, well, I'd like to work in labor and delivery. She said, oh, we don't have anything in labor and delivery. I can put you on med surg. I thought, okay, well, I guess my choice is medical surgical nursing. And I still didn't know a lot about, you know, anything that I wanted to do. And one of my schoolmates, one of the people that was in class with me, said, Janice, why don't you go over to Charlotte Memorial, because that's what it was. It had a lot of names since then, but that's what it was called then. And talk to them, because they get an extra day off every 2 weeks. They only work a 37.5-hour week. And I said, okay, that sounds pretty good. So I started in what was called preemie nursery. We didn't even have neonatal intensive care. We didn't have neonatologists when I started to work. We had residents, and they acted as the neonatologists, but they were not the specialized group that took care of those babies. Since I've been in nursing, Presbyterian actually hired the first neonatologist in the city. She came and stayed about 2 years and then left, and then they hired another one. So Presbyterian even had a neonatologist on staff before, and I think by then it was Caroline's Medical, I'm not sure, you know, now it's Atrium, but we had the first Presbyterian, which is now Novant. You know, everything is system now, Atrium and Novant, and they're in several states, more than one. But we hired the first neonatologist, and she started to work, and of course she clashed with a lot of the pediatricians because they were used to coming in and doing their own thing with those babies. They were used to taking care of them themselves. They didn't have anybody over them to take care of their patients. But eventually it all worked out, and it really was a good system, because those specialized people, and I'm gonna talk a little bit about that with nursing, but they know more about what's going on. I brought my bio because Gary's already critiqued me today, telling me, you need to be careful because they won't understand if you're talking about when you were working as a nurse or when you were working as an instructor. Well, I worked more as an instructor and went more places. I've never really worked that much as a staff nurse. Now, I work now in neonatal intensive care as a PRN nurse, which means I just work a little bit, 4 days and 6 weeks, that's all they ask, and that's what I give them. So 4 days and 6 weeks is enough to keep me current and keep me from going crazy thinking about what am I doing sitting at home all the time. Now that I'm getting out of some of that stuff that Nancy was talking about, I'm not involved in near as much in the city as I was, and it's kind of nice because I'm backing up with, I'm not secretary of every committee that I'm on except the ABC board. I'm still a secretary. And by the way, my Man of the Year cohort is in the back row. Gary Neely was Man of the Year when I was Woman of the Year last year. So, and I said, that's funny, both of us are on the ABC board. I wonder if they realized that when they picked us. But anyway, there are a lot of things going on in the city, and I think we have 2 council members here, Kenneth Reeves and Phyllis Harris, and there is so much going on that you can get involved in. And it's always nice to be a volunteer in some group because you can see it from a lot of different aspects. So if you don't have anything to do and you have some free time, Phyllis or Kenneth will tell you where you need to go to think about volunteering for the city. But I've always enjoyed things like that. I laughed because I used to tell my students, I've never minded a captive audience. If you have to sit here with me, that's fine, but I'm not going to keep you overtime, which some, faculty and speakers do. But I always enjoy giving people I brought this because I've done this all of my life. I showed this to my sister the other day. My students gave me this one of the first years I taught. They gave us funny gifts every year, and this is a soapbox, and it says, Janice, get off your soapbox. So, I've always been able to give people my opinion and talk about what I think is important. Sometimes that gets me in trouble right now on Facebook, but, I still kind of put my opinion out there a little bit. One of my students, Bobby Ryan's sitting in the audience, and his daughter was my student from, what year did she graduate, Bobby?
That's so long ago, I don't remember.
Allison has been a nurse for a long time, and she was a super, super good nurse, very smart, and did everything like she was supposed to, so she really was good. But, I have a lot of people. I was doing the little tour the last time Camille asked me to do something. It was me and Delina maybe and Nancy. We did a little tour of a group of Girl Scouts or Cub Scouts. I can't remember. Anyway, one of the students pulled me aside over there a little bit, and she said, Janice, you're my instructor. I said, what was your maiden name? You don't remember people. She said she graduated 20 years ago, but it's like people stop me and say something like that, and I'm always, honored, but I don't usually remember that. I might remember their face, but most of the time, unless they were really bad or really good, I don't remember them that much. So, but I taught for about 35 years. And the rest of the time I've done a little bit here and there in different areas, but I always enjoyed spending time with students, and I taught class, and then I was in the hospital with them. So that's definitely an experience. I'm only going to say one more personal thing, and then I'm going to move into some of this stuff I said I was going to talk about. I recently had a pacemaker. And Gary told me one of the days, I can't remember if it was the day I was going home or not, but he said, you're so mean. You're so mean to these people. And I was very irritable, I have to say. But it was like, nothing was right. And I thought, if I was the nurse for this patient, I would be doing da-da-da-da-da. But it's a different game this day.
Pacemakers can fix a lot of things.
That's right, they can. And I think it kind of fixed my meanness a little bit. I don't know, you'll have to ask Gary and Phyllis.
Judge of that.
Just a little bit.
You'll have to ask Gary and Phyllis. But, you know, we were talking in here one night, and this is kind of how this got started, because I was talking about, and I'm gonna have to get Gary to show me again about this thing. I actually graduated in 1974. So I have been, it's been a long time when you think about technology and some of the things that we do different. That's why I'm only working 4 days a week. I can barely keep up 4 days a month. It's not even a month, it's in 6 weeks. But we started talking about this in here one night. I think Alice was one of the people that we were talking about an iron lung. And I said, I can remember there was a patient that came to Charlotte Memorial that was in an iron lung. She was a polio, you know, victim, and she was in an iron lung, and she would come into the hospital every now and then for respiratory infections, and it was fascinating to watch that thing. This is a child, so it's a smaller one, but you know, when you'd walk into that room, it was just a lot of noise and a lot of equipment. It was this massive thing that took up the whole room. And I laughed because I said, I worked 3 to 11 for a long, long time at Charlotte Memorial, and me and some of my coworkers would roam around the hospital, and we went down in the basement. We'd go across over to the rehab hospital because they had better food in their little snack bar, and we'd go over there, and we found a room walking around in some of those halls down in that sub-basement, not just the basement, in the sub-basement, and there was a bunch of these. They must have had about 6 iron lungs in that room. So, you know, it has been in my nursing lifetime. Now, what took the place of this? Anybody know what took the place of an iron lung if somebody had polio and they couldn't breathe? We trached the patient and put them on a ventilator, and the ventilator was positive pressure that kept their lungs open and kept things aerated so that they could exchange oxygen and live. Now, my babies have never been on that, but my babies have been on something that some of you might have used, bubble. Well, ours is bubble CPAP, but you might have used BiPAP, or what's the other thing that people use? CPAP that adults have to use. And my babies have been on that. So this is kind of a, you know, this is an older version of what happened when you had lung problems, that you needed to have your lungs aerated so you could keep oxygen going through your body. Oh, see, Gary? I think I'm holding it wrong, Gary.
Training.
I know, okay. This is kind of the setup, just so, and the patient was in that thing all the time. They didn't ever come out of it, and you had places you could work in there to do something, but the patient never came out of that. This is just so you could see it. And I wanted to bring my uniform and my hat, my nursing cap, because I was pinned in 1974, and we were still wearing white uniforms and white hose and white shoes. You could only wear a navy or a white sweater and a cap, and you wore it. And so if you were doing CPR on somebody, you were crawling over the bed in a skirt or a dress and hose. So you're crawling everywhere to get to the patient to do CPR. We've moved to scrubs, and some people, sometimes the lay public doesn't like scrubs, but it is so much easier because they're so much easier to take care of. You throw them in the washing machine, you know. But this is what everybody looked like. Everybody wore their hat, everybody wore their white shoes and their white hose and their white uniform. And, whoops, I might get this figured out before the night's over. And what's real interesting about this picture?
We're smoking.
And we did that. And in the cafeteria. And the nurses smoked in the cafeteria.
And in the lounge.
It was everywhere.
And the patients smoked in their room.
In their room.
Yes.
I can remember going in when I was working for a group of pediatricians. I would go in the rooms to see the new moms, and I would unwrap the babies in the room, and the smoke smell would knock you over because mom had been sitting there smoking with ashtray on the table and sitting there with the baby. So we've come a long way with a lot of things. I've never been a smoker, so I'm very anti-smoking, but I know a lot of people have smoked, and it's hard not to if you've smoked for a long time. But I think this is just so funny because that nurse is sitting there with that cigarette, and she's just not thinking about the health implications at all. And this is mostly everybody wears scrubs now because it is so much easier. A lot of different colors mean where you might work. In my unit, the lactation consultants all wear pink. Respiratory therapy all wears black. The nurses wear blue and white pants and then multicolored tops. It doesn't matter what color top. But in the hospital, pharmacy wears a gray. Somebody wears a green. There's a kind of a scrub color for the different areas of where you're working. But these are students. You can tell by their patch. And they're trying to teach each other, I think, about blood pressures. Not sure. Men in nursing, and I'm going to talk a little bit more about that. I want to kind of go ahead and get these out of the way, but we have a lot more men in nursing now than we ever did. It's still less than 50%. It's more like about 35 or 40%. I looked it up on some of the Board of Nursing website information, but more men are going into nursing because it is a very stable profession. You're not going to be downsized. If you're working in a hospital as a staff nurse, you're pretty much going to have your job. Or what I used to love to tell my students, don't worry about it. If you don't like what you're doing, you're still a nurse. Go find another job. You're still a nurse. So if you don't want to be a neonatal intensive care nurse, go work with adults. Why anybody would, I'm not sure. But you could always go and get another nursing position. So but the men that are in nursing, I think, is good because I gave a report the other night. It was the night nurse coming on, and I looked at him and I thought, you look like you're about 12 years old. But he's fairly new, and he was working down in the pediatric intensive care, and he got pulled up to us, but it wasn't phasing him. He was fine with being in neonatal intensive. So the fact that we've got men in nursing, I think is good because I think we need the role models to show that, this is not just a woman's profession. This happens to be a service person. And we've had a lot of nurses come in from, they were in the service and they were either med techs or corpsmen or something like that, but then they come in and they decide they want to be a nurse, and it's a good transition. And this just kills me because these are the old cribs. Those slats are so far apart, you could not put a smaller baby in that crib because that would be very dangerous. But all of that's kind of my, I worked in a pediatrician's office for a lot of years, and that's all that safety information that I was always trying to get across to parents. But, usually 2 beds in a room was not a big deal. We don't have semi-private rooms now on pediatrics. They're all private. But this is pretty much where we came from. COVID was really a big deal for nurses because, first of all, people were super sick. If you were working with adults, COVID patients were sick. 1920, when this first started, the novel coronavirus 19, and the nurses were so stressed from taking care of the sick patients, but then they stood a chance of becoming infected themselves. Whatever you think about vaccines and shots and all that, I think the fact that we've had COVID vaccines, people are not as sick in the hospital. They may get it and they may be hospitalized, not as many of them, but they're not going to be as sick, and it's not going to be the stress that it was when COVID first hit us. 2019, is that right? 2020. And if you think about either wearing a respirator, which some people, if they have a beard, they had to wear a respirator, which was something on their back that ran the system, but a lot of us just wore the face mask. But then you had to have the fluid shield. This lady's got that. She's got a face mask that comes from her head, and this one's just got a regular mask with a fluid shield on it. But it's awful. If you have to spend 12 hours a day like that, it's miserable. We're wearing masks again now at the hospital because of the flu. If you're forward facing to your patient, well, my patients are all in isolates or, they're in cribs, but we have to put a mask on if we're right with our patient. But I got a note on my Facebook page, that's how they send information, masking stops Thursday of this week. I guess because it's spring and because flu season's not as bad right now, I don't know, but we've had to go back to masking. It was voluntary for patients coming in, but the nursing staff had to wear a mask, especially being right next to their patient. Now, this is what and I'll talk a little bit about some of my patients, but this is one of my little babies that has oxygen and a feeding tube, and those little stickers on him are for using cardiopulmonary respirations, and then pulse ox is on his foot. But this is what my babies look like, and this is really one that's a little bit healthy. I asked some of the nursing staff that I worked with, what do you think is different in the past 50 years? They have I'm the most senior person there. I don't ever have to work my holiday. They take me off of it and put me somewhere else because I've got more seniority than anybody. But I asked one of the nurses, she's probably 10 or 15 years younger than me, but I said, what's different, Sarah, about nursing now? And she said, our babies are a lot smaller and they're a lot sicker. So, when I was first at Carolina's, not Carolina's when I was working there, but Charlotte Memorial, our kind of cutoff date for a baby was like a 27, 28 weeker. Now we have 22 and 23 and 24 weekers that survive and go home. But if you were born at 22 weeks out of 40, we tell them, plan on your due date. Don't think you're going home before whenever you were supposed to actually come in the hospital. And then it might be a couple of more weeks after that. But we have some patients, if they've got really bad lung situation, they might be there a year. And then once they go home, the parents might have to deal with a lot. They may have a trach, they may have a gastrostomy feeding tube, they may have, a lot of things that we have to teach the parents how to take care of it, because there's not going to be somebody going out to take care of this stuff when the patient's at home. They might have a little bit of nursing care, but not much. Usually not much at all. And skin to skin is wonderful. It's usually the mother doing skin to skin, but we have a lot of dads that come in. I was working the other day, and this dad comes in, takes his shirt off, and puts the gown on, and sits down. He's ready. The mom of the baby was still working and wasn't going to be there for a while, and he's been coming in every day and doing skin to skin. So put that baby up next to him. And the babies do so much better if we're able to get that started really early on. So I just thought this was good. This baby's still on oxygen and got a feeding tube, but Dad's doing his skin to skin. Now, this is a sicker baby because that's a triple lumen catheter, which means this baby's getting some kind of fluid, probably getting lipids, which is the fats that we give them, and then also probably has a med line. So this baby is, and this line, if it's put in, and it used to be that the doctors did all of this, we had to call a surgeon to come in and do a central line for us. The surgeon had to come into the unit and do it. Now the nurse practitioners do it, but this is a peripherally inserted central catheter. It might go in right here and terminate in the heart, or it might go in somewhere else, but it's usually in one of the arms, and it terminates in the superior vena cava, and that way the medicine is there. I mean, we can get stuff in, but it's just something you have to be a lot more careful with. But almost all of our babies have central lines. So, unless they're close to going home, and they may still just have a peripheral IV, but most of them have a central line. I'll put it way over there, but. Now, this is a couple of different feeding methods of my babies. This baby's got a tube in his nose, and she's putting the feeding in the syringe, and then she's going to let the baby suck on the pacifier. So we try to get them used to sucking so that they will eat. Now this is the one that blows my mind. I've never done it, but a lot of the staff have spoon feeding. If they're really small and we can't get them to suck a nipple, then they've got this special little short handled spoon that they put the milk in the spoon and just keep tipping it into the baby's mouth. The first time they told me about it, I said, what? A spoon to feed that 24-week baby? But this is one of the ways they're doing the feedings now. This is just a good old-fashioned preemie. He's looks like he's doing pretty good, but this feeding may take 30 minutes. And if you have 3 babies or 4 babies, you know, your time's kind of running. But this is a good way to think about the different ways that we feed the babies. Okay, see, and I've already said all that, so I'm already going to be ahead of the game. Nurses Week is May the 6th through the 12th. So if you know a nurse, send them a little note and say you're appreciated. But the hospitals try to do a big deal, but for the most part, there's not a lot of appreciation shown. But that is just a time when the nursing staff all around the globe, Nurses Week is everywhere, not just here. The thing that I like to talk about, because of the fact that how long I've been in nursing, there's a lot more formal education now than there ever was. Nurses used to live at the hospital they were going to school in. The hospital diploma program is where the majority of nurses were educated, and you lived there and you were kind of the hospital's slave labor. When I first started teaching, we still had some students on 3 to 11 and 11 to 7. And they would have one instructor for the whole hospital, and there might be 20 students out there. And guess what those 20 students were doing?
Everything.
They were taking care of the patients, everything. You're exactly right. And that instructor, before, it wasn't even as easy as a beeper. You had to try to call the floor where the instructor was to find somebody if the student needed help. But education is so much better now, having been in nursing education for 30 plus years. It really is a lot better. The majority of nurses now are educated at the baccalaureate level, so they go to a 4-year nursing program and get a BSN, a baccalaureate of science in nursing. And I was an associate degree nurse. Nancy was an associate degree nurse. North Carolina has a lot of 2-year programs, but now the majority of those graduates go on to a BSN. There are a lot of what we call BSN completion programs, and those students take 2 years at the community college level, and then they go the other 2 years in a university system, and they end up with a BSN. The other thing, a long time ago, and I remember this, you had to stand up when the doctor walked in the room.
No, boy.
If you were sitting down doing charting, you had to stand up and give them your seat. Alice remembers. It was definitely a subservient role, and it is far from that now. I have seen nurses, not that I have any problem with most physicians, but I have seen nurses call them to task when the nurse knew more about what was going on than the physician did. But it's not like it was with, 50 years ago, thinking about the subservient role. Doctors really did still treat nurses as assistants then, pretty much their assistant to help. And even though, nursing's kind of an extension of a woman's caregiving, it wasn't really thought of as a career. Now it's thought of as a career. And nurses go on and get PhDs in nursing. My teaching partner at Presbyterian got a PhD from a really prestige school. I'm blocking on it right now. That's what happens when you get 73 years old. But they get PhDs, they get DNPs, which is a Doctor of Nursing Practice. So, there are doctorate levels, and a lot of nurses are doing that. It's just so much easier for nurses to move into that kind of upward mobility track. Nursing is the largest workforce in healthcare. Nobody else has as many people as nursing, working in the hospital and in other areas of healthcare. But today, nurses, I used to love to tell my students, if you don't like what you're doing, go find another job. You're still a nurse. Forensic nursing is something that's really big now. Informatics. I have a friend, he wasn't ever my student, but my teaching partner's son works with a company that he travels all over the world to teach people about the charting system, because nothing is done on paper anymore. Everything is done in the computer. And informatics is a real big deal. I already said that, okay. Yep, I already said that. Talked about climbing on the patient's bed in a skirt, try to do CPR.
How big are your babies?
How small are my babies? It's probably a better way to say it. Well, I had one the other day that was 26 weeks after being born at 23, and he was up to 2 pounds. So, a lot of mine start, and if you think about a 14 or 16 ounce ketchup bottle, some of them start at about that size. But we have such good survivability now than we ever used to. It's just a different world because of neonatology and the fact that we have specialized units, neonatal intensive care units and neonatal nurse practitioners. So it's so much better than it used to be. But the majority of our babies, if they're really early, and see, even this is so different from when I first started working. You were either term or preterm. And when I worked at Charlotte Memorial in the preemie nursery, the criteria was kind of if you weighed 5 pounds or more, you went to the regular nursery. If you weighed less than 5 pounds, you came into my nursery. And now we look at gestation, we look at, they might be early gestation, or they might be late preterm, or they might be failure to thrive before they're even born. So you have to look at so many things because you're not going to hold that baby to just because he's 25 weeks, you're not going to hold him to that criteria. But like I said, we do so much different now that it's so much better. I don't think I mentioned that you have to get a state license in North Carolina to be a nurse, and it's about a 300 question test now. It used to be 2 days when I took it, and probably when Nancy took it. You went to Raleigh, you stayed 2 days, you spent the night in a hotel, and you had to go back the next day to take the other parts. It was like 5 different tests. And in some weeks' time, you got your scores in the mail, and then you could work as a nurse. But now we pretty much put those people to work knowing that they're eventually going to pass NCLEX, and it's so much quicker from the time they graduate till the time they get to take their NCLEX exam, and that's National Council State Board Licensing Exam. That's who administers the test for nurses. Okay, back to programs. There's a lot more bachelor's programs today. In the early 80s, there were only about 170 college-based programs, and now there's it's probably even different now. There's probably over 900 bachelor's programs across the state. But that was a good question, Gary.
What's the smallest baby
that I've ever taken care of? And see, I don't take care of those really sick small babies until they get a little bit healthier. And they tease me because they say I don't like the spots in the bed, and I don't like the big ones, the 10-pounders. We have some of those if the mom's diabetic. So I like them in the middle, but the smallest one that I've actually ever taken care of was probably about 1.5 pounds. And he was there for a long time. But, again, size is not that big a deal anymore. I have a lot of parents say to me, does my baby have to weigh 5 pounds before he goes home? Or does my baby have to weigh 6 pounds? Nope, doesn't matter what he weighs as long as he's eating and gaining weight, as long as he's maintaining his temperature without being in an ice sweat, and as long as he is, growing and developing like he's supposed to. I've sent babies home at 4.5 pounds and thinking when they go out the door, oh my gosh, good luck to those parents. But that if they're doing what they're supposed to, they can go. When you think about the fact that before, when I first started in nursing, people stayed in the hospital a long time. If you had a cardiac cath or you had anything, you stayed in the hospital for a long time. I was teasing my brother-in-law not too long ago because he had a cath and had his femoral vein. That's where, we put those people, we attached them to the bed with a C-clamp. They couldn't move because that C-clamp was putting pressure on the groin. Well, now Gary had his on his wrist and he went home the next day. Wasn't it just the next day? I mean, you know, things, we don't keep people like we used to. We don't keep them in the hospital. They don't have near the bad recovery.
They would check you in the night before also.
Exactly. You went in the night before. Which that reminds me, I wanted to say something. Before, we used to do PM care. Does anybody know what that is? When you went around in the evening before you got ready to go, and it wasn't 7 to 7 shifts all the time. When I first started working, it was 7 to 3, 3 to 11, and 11 to 7. And you went around to all your rooms and emptied the trash. This was the nurse's duty. You gave the patient a back rub. That was part of PM care. And you kind of got them set up for the night so that maybe they would sleep good. But there is no PM care anymore. If you need something, you ring your call bell and they'll come and help you. No sleeping either, trust me, I know that. But shorter stays now for everybody, regardless of what the problem is, means that the nurse has to be more efficient when they think about educating their patients and caring for them. Really?
Are there any classes when parents have to take those small babies?
Oh, yes.
Okay.
We make them do everything. We used to make everybody do a CPR class, but we don't do that anymore. They can watch it, but we have a lot of classes, and especially if they have, you know, like if they have a gastrostomy tube, or they have a, you know, like the gastrostomy tube into the stomach, which gives them the food, or if they have a trach, they're on a ventilator, and some of our babies go home with ventilators. They may only have it at night, but they have a ventilator and a trach to keep them, you know, oxygenated and breathing through the night. Some of those patients might have a nurse for a little bit, but still not very many people have nurses. Like, they'll have a service that comes out and the nursing care is done with some of that. But yeah, we teach them a lot of things. You know, you kind of start out teaching them how to change a diaper. I'll send some of these around. You talked about my smallest baby. These are what most of my babies go in. And this is just a regular newborn. This is not even, no, this is a 1, I'm sorry. Preemie, preemie 2, preemie 1. And these are what my babies fit in these diapers, not these. We have some of our bigger ones that fit in these, but most of my babies are so much smaller, they can't even wear the regular diapers. And how many of you have your own blood pressure cuff at home? Well, this is the blood pressure cuff for one of those little 2-pounders. And this just gets hooked to the machine, put on the baby's leg, and you get a blood pressure. That's the small one. This is our biggest one, and this one's not a real big one, but this is probably a, you know, getting ready to go home baby, this 4. But that's the biggest one we have. And then that's the smallest one. So,
How many babies do you take care of at a time?
another good question. Hopefully 3 or 4. I talked to one of my good friends that worked. I worked on Saturday, and she had been there the day before, and I had her assignment, and she sent me a text asking me how they were doing. It's a set of twins that was supposed to go home yesterday, and another baby that's still in an isolate, really small, and having some problems with breathing. But, you know, she had 4 babies, 2 of them on some kind of oxygen respiratory support, and something else that was odd. And she said, I couldn't get it all done because she had those 4 babies and they were all kind of sick. If I have 3, I'm doing good to keep up. But 3 or 4, now, and I'm only on what we call the special care side. They're getting ready to go home. The intensive side, it might be 1 nurse to 1 baby, or it might be 2 nurses to 1 baby, depending on how, you know, if they're on, I can't believe I'm blocking on everything. If they're on really high oxygen and lots of stuff. And I used to love to take my students, when I would have students over at Carolina's Medical, I would take them up to the cardiovascular unit. It was a PICU and a cardiovascular intensive care unit, because I liked for them to see ECMO, because they had a lot of ECMO up there on babies. And, you know, if you can get somebody to see that circuit one time, it's such a, you know, the blood is coming out of their vein here, their vessels, like with a garden hose, and getting oxygenated in a machine and then going back in. And it's just, you know, awe-inspiring to think somebody made this piece of equipment to get this person to survive. The longest I can remember a patient on ECMO was a little boy that was in a house fire. And they thought, let's try ECMO, you know, rest his lungs and rest his heart. And he survived. So, you know, he was really sick when he first got there. But there are so many things, the technology today is just so, you know, far better than we ever had. Okay, I've already talked about men in nursing. I don't want to talk about that anymore. Okay, gender pay gap is one of the problems that we still have. Men and women, we still have, you know, there's a gap. If you're a man in nursing, most of the time you're going to make more. Most of them go into administrative, supervisory kinds of things, but the majority of in-hospital male nurses, for whatever they're doing, make more. The Affordable Care Act made a big difference when you think about team nursing, and we do still do a lot of primary nursing, but we do a lot of team nursing, so that you've got 2 or 3 people on the team that's taking care of that, especially with adults, with that adult patient. Okay, I'm going to finish up here in just a minute, but I wanted to read you something. This is something that one of my co-workers, and she was actually my student, because she told a whole group of nurses one day, the first time I really ever saw Janice in action, she was chairing the board of nursing. She said there were a lot of people in that room, and she was telling them when they could talk and when they had to be quiet. And I even got to tell lawyers when they could talk and when they had to be quiet. So I enjoyed that. I was chair of the board of nursing 3 times, elected to that position. But this is something that Shay sent me after I asked a lot of them to send me information about what do you think is different in nursing. She said, in the 80s, we had to wear our nursing cap representing the nursing school we attended. And trust me, it had to be on your head all the time. She said we wore all white dresses, white nursing tops with matching white pants, white support hose, and white SAS nursing shoes. I didn't wear SAS, I wore those leather
Nursemaids.
yeah, but anyway, we were expected to keep our nursing shoes clean, and I have seen instructors send students home because their shoes weren't clean. So, you know, just whatever that particular nursing instructor felt like she wanted to talk about, or he. Hair up and off your collar, white or navy sweaters. You never addressed a doctor by his first name, his or her first name. You always said Dr. So-and-so. And when you were calling out you had to use the paging system to get nurses to call back if they had a call or a lab result or something, and you always said, Mrs. Brown, can you please come to the desk? You had to use Mr. or Mrs. to call the patient over the intercom. Shifts were 8 hours. I think I already said that. I started on 3 to 11. I worked 3 to 11 for 3 years. And I didn't realize the rest of the world didn't operate on that schedule. I thought when I took it, oh, this will be great. I can sleep late, and then I can do stuff when I come home. And I mean, you can go to the grocery store and it's going to be totally empty, but nobody else operates on that schedule. So now we really don't have a lot of 3 to 11. It's either 7A to 7P or 7P to 7A. We didn't do self-scheduling. You got your schedule handed to you about every 4 or 6 weeks. Nobody did their own. Now we do our own. I put mine in the other day. Just told her what days I wanted to work. For a while, Shay remembered this, and I had forgotten. We gave a report on a tape recorder. You don't think that wasn't horrendous. We sat in the nursing lounge and recorded report, and those people that had adults might have had 5 or 6 or 7 patients. You recorded report on those patients, and then the next shift coming in would sit down and listen to it. That way you always had somebody out on the floor to take care of the patients while you're getting report. Now we pretty much, we try to do it in 15 minutes, but we just tell parents, if you can just wait a minute, we'll get to you in just 1 second. Let me give this nurse report so I can get out of here. But we do it a little bit differently now. There was no computer charting. She says she doesn't remember any. In the 80s, she said they had a computer then, but it was just for meds. No other charting on the computer. At the end of every shift, you had to sit down and look at the doctor's orders and make sure they had been put into the chart. Because the doctor wrote them, the secretary inputted them into the chart, so a lot of ways for errors. I can remember when I was working for the pediatricians that I spent a lot of years in their office. Dr. Blair Bryan called me back to his office one day. He said, Janice, come back here. I want you to look at this chart. Well, my name was in this chart that he was reviewing because the patient had sued. It was suing Charlotte Memorial Hospital. But he said, do you remember anything about this patient? I said, Dr. Bryan, no. I said, I can remember that I gave him, looks like I gave him a drug right here because you had to write it out, what you gave. We didn't, everything was handwritten. But he was trying to review the chart because the family was suing the hospital. And I did start to remember it after that a little bit, but it was kind of a pharmacy med error, but the nurse carried it out. So it was kind of a bad situation, but he was reviewing it, trying to help out the hospital when he reviewed the chart. Meds weren't locked up. Shay says she remembers getting out a vial of morphine, leaving it on her desk, and any nurse that needed morphine for their baby came and drew some out of that vial. And it was not accounted for, it was not charted anywhere, you just pulled it out of the machine and then put it on your desk. Things are a lot different now. They will call you and ask you why you took something out 30 minutes later than it was supposed to be, or call you and ask you why you tried to take something out too early. Because the Pyxis and the pharmacy are looking at all that, and they're really, it's for patient safety. So, but it's definitely not like it used to be. And she talks a lot about aminophylline and caffeine. That's just a difference in drugs. We used to use a lot of aminophylline, but now babies are on caffeine. They get their morning dose of coffee. If they're not breathing or they're not having good respirations, they'll get caffeine. They almost all get a 24-hour antibiotic rule out. Any baby that used to be admitted got 24 hours of ampicillin and gentamicin. We don't do that anymore. We know there are a lot of problems from drugs that they're not needed for something in the body. Again, she talks about the central line. You had to call the surgeon. And now the neonatal nurse practitioners come and do it. I mean, they can come and put one in like 5 minutes or less, and then you got your line for your baby. So it's a whole lot better. Babies were intubated for a long period of time, and now that we have been using the caffeine and some of our other drugs, they're not intubated for nearly as long. If a baby really comes in and they've got bad lungs and we've put an intubation tube down into their lungs and they're hooked up to a ventilator, they may only stay on that ventilator 2 or 3 days. And that's kind of like the norm, and we try to get them off as quick as we can. We have a lot of nasal cannulas, and we do room air trials. If the baby seems to be doing okay, then we'll put them on a room air trial a couple of times a day, just to see if they can do it, and then they move on from there. We do a lot with oxygen saturation limits. We used to never look at that, and one of the bad problems from having too high an oxygen saturation limit in your body, some of y'all probably have you can put it on your finger and tell what your O2 sat is. Well, some of our babies would be over 100 all the time. Well, the big problem from that is retinopathy of prematurity. Stevie Wonder is blind because he had retinopathy of prematurity. Got too much oxygen and it wasn't ever treated, and so the vessels, now we can even treat it. You can do like a laser treatment and take care of it. Our babies are seen by the eye doctor every 2 weeks to check retinopathy of prematurity. So we don't have babies that have problems with, not being able to see because of some of what we're doing to them. The only other thing I just wanted to mention, and this is so much everywhere, it's not just in nursing, but incivility, bullying, and workplace violence. I'm sure some of you have seen the news stories about, there was one in Ohio not too long ago, because I had a good friend that had a friend working there. Somebody came in and was upset about their family member being treated a certain way and shot a doctor and a couple of other people in the unit right there. It's happened in doctors' offices. They come back in, family comes back in mad about something, and they have a gun and they, start causing lots of problems. But that's one of the things they're really, especially the American Nurses Association is trying to look at, workplace violence, because you're pretty much stuck. If you're there taking care of that patient, there's not a whole lot you can do. And if they, if they are intent on harming somebody because they feel like we've harmed their family members, then that's something that we're going to see more of. And I think especially as people's mental health is more off kilter even than it is right now. Okay, I am gonna stop. I have more stuff, but I'm not gonna bore y'all with it, and I will see if there's anybody that has other questions.
I have a comment. My last, adventure at Presbyterian Hospital, they're doing more screening, like they screened me for guns when I was
Oh,
going
yes.
into the emergency room. Both times, coming in the front door.
Family members are being
Yes, I was screened.
checked to make sure they don't have a gun on their person that the poor nurse doesn't know about.
And so that was the first time that I've actually been
Okay,
screened for
good,
guns.
interesting.
Did you get your gun back?
Was it Alice's or Dow's?
You know better than.
Well, I will say something. She's talking about all these babies and stuff that she's taken care of, but she was a godsend to us when our son was born, because I didn't mind calling her at 3 o'clock in the morning. I didn't want to call the doctor, so I'd call her.
And
Yeah,
you,
what do I do?
and you weren't the only one.
I know.
I had some of the physicians giving my number, and they would call me in the middle of the night. So, you know, the parents felt better calling a nurse that they knew rather than waking up the doctor. So, you know,
That's
yeah.
exactly how I felt, calling my sister.
Did you
I
get a
didn't mind
family
calling
discount?
her.
Did you get a family discount?
And I did, yes.
I started to say, I didn't even
Pediatric
get
clinic.
paid for those phone calls. Gary?
What's that graduate nurse, when she's hired at your hospital, what's the starting pay for that?
Oh, gosh, and you know, I just knew that the other day. We just all got a raise at Novant, so the starting salary is about, high 20s to 30. And I'm a lot above that, because I've been there a lot longer. But yeah, high 20s per hour, 30s, Alice?
And then there's shift differential, and then
Shift,
there's
yeah.
weekend add-on, and there's all kinds of ways.
Exactly.
If you work in the hospital to
Yeah.
make more and more and more.
Yeah,
My daughter started a little over 10 years ago, and I was surprised her pay then, I think it was about $21 an
and she's been in it 10 years already?
hour.
Oh.
No, that was her first job.
That was her first starting, okay. See, I had one of my first Charlotte Memorial pay stubs not too long ago I happened to find, and I thought, gosh, I sure didn't make any money.
And another thing with COVID and everything, my niece's husband is a nurse, and he went to work in Charlotte, and then he became a traveling nurse.
Oh,
He went to Wyoming for 6 months. He went to Raleigh for a year. They put him up in an apartment, and they make so much money
oh yeah,
that, you know, he's got 4 girls, so it's
it's
really,
good.
yeah, it's
Well,
really
we
good.
had a little bit of an issue. We had so many travelers at one time in the NICU. We were almost 50% travelers, and the rest of the staff was not liking it, because when they told people how much money they made, the staff was not happy. So they started right then trying to clear out the travelers. We have 1 right now. We have some that have hired on to Novant, but we had like 50 travelers at one time. We've got a staff of, you know, about 150 nurses, but it was not pretty when the rest of the staff found out how much those travelers were making.
I don't think they're reaching out to nurses as much now. It's
No.
backed off a little bit.
Yeah, that's right. That's a good point, Carolyn, you're right.
Is there a shortage of nurses?
There is, and there's gonna be worse. By some of my statistics, because of the fact that we're an aging baby boomer, whatever population, it's gonna be worse. By 2030, I think it said, some of the stuff I was looking at with the Board of Nursing said in North Carolina, we'll be about 20,000 nurses short.
Wow.
So, you know, if you're 73 like me, and I'm talking, you know, even if you say 10 years, there's gonna be a really big nursing shortage, and especially in North Carolina. You know, some of the northern cities can pay more and hire them away from places like, you know, rural states a lot of times, but it's gonna be worse. When I was on the Board of Nursing, all those statistics just fascinated me, because I think, and one of the reasons we can't get any more nurses into nursing programs, we have some new programs, but we can't get faculty because they're all aging out. So the faculty are not there.
Really?
People don't want to go to work in a school that teaches nursing. There's a new program, they just had like 8 or 9 graduates. Johnson & Wales has a brand new nursing program. So, you know, anybody that's got a, David,
Belmont Abbey has it too.
one of our people at Queens, when I was there, he came to work to be the director at Johnson & Wales. I said, David, he said, I'll have small classes for 3 or 4 years. It'll be wonderful. But yeah, that's the other thing is we're not going to have enough nurses. So, you know, if you have children or grandchildren, it really is a great profession, and I've loved every minute of it. And like I said, I've done pediatric intensive care, I've done office nursing, I taught, you know, and now I'm back into the NICU, which is really the only other place I've worked in the hospital. I took students everywhere. I had to take them to Gaston one time to psych. When I said to her, I said, I have never done psych nursing in my life. She said, oh, it's easy. They'll tell you what to do. I said, okay. And the staff really were very helpful, but I was just, you know, praying the whole time I had those students over there because I didn't know what I was doing. But it's, you know, if you really like it where you are, then you kind of make it your own and stay, or, you know, find something that you like better. Well, thank y'all. I appreciate it. I laughed and told Nancy the only thing is I couldn't find my uniform and my cap. I got it somewhere, but I couldn't find it.